Welcome to this Dr. PPT.in medical update. Today, we're diving into a topic that is absolutely central to our work as endocrinologists: contraception. You know, as hormone specialists, we live and breathe hormones. But truly mastering hormonal contraceptives for our complex patients? That's not just a nice-to-have skill. It's a core competency that can dramatically change patient outcomes. Here's a quick look at our game plan. We'll start by talking about a critical gap in our practice. Then we'll unlock the secrets of progestins and estrogen. After that, we'll get practical and apply this to specific endocrine conditions. And finally, we'll take a peek at what's coming next. Let's get started.
So, first things first, why is this so incredibly important for us? Well, the truth is, even though we're the hormone experts, there's often a pretty big gap when it comes to our hands-on practical knowledge of all the contraceptive options out there. This quote from an upcoming Endocrine Reviews paper just hits the nail on the head. Hormonal contraceptives are so much more than pregnancy prevention. They are literally therapeutic power tools for managing the very conditions we treat every single day, from PCOS to challenges in our diabetes patients. Okay, to really master this, we have to start with the foundational element, the absolute cornerstone, and that's progestin. Think of it as the master key. It's the essential component, the real backbone of every single hormonal method. So what exactly is a progestin? Simply put, it's a synthetic version of progesterone, and its power comes from a really clever three-pronged attack. It stops ovulation, it keeps the uterine lining thin, and it thickens cervical mucus to create a roadblock for sperm. That's the core playbook. But here's the kicker, and this is maybe the most important point of our whole discussion. Not all progestins are created equal. They have these distinct clinical personalities. Some are anti-androgenic, which makes them fantastic for patients struggling with acne or hirsutism. Others are androgenic, and they might actually make those symptoms worse. Getting this right is where medicine becomes an art. So let's make this real. A patient with PCOS walks into your office. Which progestin do you pick? If you choose an anti-androgenic one, like drospirenone, you can actually improve her symptoms. But if you were to pick a highly androgenic one, like levonorgestrel, you could inadvertently make things worse. This one choice has a direct, tangible impact on your patient's life. All right, so we've covered the progestin master key. Now let's talk about its partner, estrogen. In combined hormonal methods, estrogen isn't really the main driver of contraception. It's more like a vital supporting partner, and it comes with its own unique set of benefits and risks. So, what does estrogen bring to the table? Three main things. First, it stabilizes the uterine lining, which means better cycle control and less breakthrough bleeding. Second, it adds another layer of security by helping suppress FSH. And third, and this is a huge one for us, it boosts SHBG, which soaks up free androgens and is a massive help in managing conditions like hirsutism. But here's the trade-off. There's always a trade-off, right? The price for all those benefits is an increased risk of venous thromboembolism, or VTE. And this one risk is probably the single most important factor that guides all of our decision-making when we're even thinking about using an estrogen-containing method. Okay, we've got the pharmacology down, now for the fun part. Let's apply all this knowledge directly to our endocrine patients and see how it works in the real world, in your clinic. Let's start with PCOS. For these patients, combined hormonal contraceptives are our first-line therapy, not just for periods, but for actively managing their hyperandrogenism. And the key is to use what we just learned. Pick a pill with an anti-androgenic progestin like drospirenone. And here's a pro tip. Consider continuous use. It keeps those androgens down without that rebound you can see during the placebo week. Now let's talk about our patients with diabetes. This number, an A1C over 6.5%, this is our big red flag. It's a clear signal that pregnancy needs to be put on hold until we can get that glucose under better control. For the safety of mom and baby, effective contraception here is simply non-negotiable. So, what are our go-to options? Well, the great news is that the newer low-dose combined pills have a pretty minimal effect on glucose metabolism. But one thing we definitely want to steer clear of is DMPA, the depot shot. It can have some nasty effects on HDL and might even worsen insulin resistance. And what about our patients with obesity? For the most part, efficacy isn't a problem, with the one major exception being the patch. But honestly, the much bigger headline here is the VTE risk. Obesity is already an independent risk factor. When you add estrogen on top of that, the risk doesn't just add up, it multiplies.
This is why progestin-only methods, like an IUD or an implant, are very often a much, much safer choice.
All right, let's wrap this up by looking ahead. The world of contraception is moving fast, and there are some really exciting new options on the horizon that are going to expand our clinical toolkit very soon.
I mean, innovation is happening everywhere you look. We already have a pill with a brand new estrogen, estetrol, that might be safer. And get this, male hormonal contraception is finally looking like a real possibility, with things like a transdermal gel in late-stage trials. The future is all about having more and better tailored choices for every single patient.
So let's bring it all home. The biggest takeaway here is to start seeing contraception not just as a way to prevent pregnancy, but as a powerful therapeutic tool right in your endocrinology practice. The most important clinical decision you'll make is picking the right progestin personality for your patient-specific needs. Getting that right lets you manage everything from PCOS to diabetes so much more safely and effectively. A PowerPoint version of this presentation is available for you to download in the library section of drppt.in. Thank you so much for joining us for this medical update. Now, the only question left is the one on your screen. Which patient will you help with this knowledge tomorrow?